JR or a Lima, get in there, leave an 018 wire, then use the wire in place and leave it in place. Use that as a marker, and then either with or without ultrasound. In a thin person, you can use ultrasound. In a person that's large, ultrasound is not that helpful. You basically stick the second part of the axillary artery outside the chest, and you should be able to uh, go ahead and get your sheets in. Hey, what's up, Dao? So the angiogram, so when you take an angiogram, you'll see it has no branches. But you just have the angiogram, you store that, you have the angio as your fluoro store, and then you, what's that? So you can compress the axillary on the second rib, but it's when you take an angiogram, you'll see that I didn't go into the details, but there's a thoracoacromial, there's a left internal mammary. You stay away from all that. Once you're here, there's a branch that goes to the humeral head here, and there's a part of the vessel that's bare with no branches. That's your target. Yeah. Yeah. Yeah, you see all this stuff. If this is a great spot, this is also safe, but ideally you could either use there or here, either or, it doesn't matter. But again, no branches. See, the whole segment from here to here is clean. You could stick distally, or you could stick here. You could stick here. So the important thing is dry closure when you take stuff out. So you basically will advance the balloon into the subclavian. And then as you take the sheath out, the balloon basically allows you to get a very dry field. And then you can cinch your percloses after you deflate the balloon or as you deflate the balloon. If your balloon is, remember to make sure that your balloon is far away from your perclose. Otherwise, you can inadvertently make a hole in the balloon as you're closing the perclose. So basically, the perclose is here, your access is here, your balloon is way proximal, the field is dry, the cinching of the perclose works, and then you still have your 014 wire that you can let go off at the end of the case. So it depends. Usually one works for most situations, but you have a bailout for two, you have the second one ready. So the axillary artery, this is an example I got from Jamie McCabe. It's very compressible on the second rib. So you can see this is putting pressure on the top, and you can actually literally compress the vessel. So this is a compressible location, just like the femoral head. So we reported this for the first time. I don't know if Ram was at Banner at that time. This was in 2019, where we basically had alternative access both. We had an IJ with the Protek Duo, left axillary, Impella, 3.5. This lady was a severe myocarditis patient. She was in the ICU walking the halls for a week. Ultimately, we were able to decannulate her, and she left the hospital in a bridge to recovery and left in 2 weeks. So it's very convenient, and I think there's a value in having alternative access, especially if you're planning to leave these in for a while. So my axillary concerns in the beginning were all related to how am I going to get closure? How is this going to lead to a pneumothorax? The patient's going to get a brachial plexopathy. But those have changed because now with a good technique, those are really less of an issue as much as these. Now, new problems I keep worrying about is risk of stroke, because we've seen that, thrombus, if the device stays in for a long time, and then vascular injury itself. Oozing is not uncommon. You have to recognize that you're going to get oozing. You need to have to make sure that you shove that thing all the way in and tighten up the sutures. If you have to take a secondary figure of 8, you need to do that. Hopefully you don't need a fem stop there. But I think for the most part, oozing is not uncommon in the axillary. And bleeding is up to 10%. And a lot of the times the bleeding is related to the device being in the body for a long time. This is, again, data out of University of Washington by Jamie McCabe. Stroke and TAVR. We've had a couple of axillary TAVR patients that have had strokes, and we're now, I think, rethinking this as a alternative access strategy for TAVR. I think for shock patients, it's a whole different ballgame. I think it still is a good and viable access, but you can see that the stroke rates are significantly higher with axillary access as compared to alternative transthoracic access, which is what this was compared to in this forest plot. I think our strategy now for TAVRs is to go transcarotid as a go-to alternative access ahead of transaxillary based on our anecdotal experience of 2 patients who've had complications related to stroke post-axillary TAVRs. Thrombus formation, so this is what Satya was referring to. I mean, I think the inflection point is, I think, 3 days. If you think that the device is going to stay longer than 3 days and the patient is in shock, then I think you're going to end up with a situation where you're going to have an issue related to either a thrombus or needing a stenosis that's going to need treatment either with angioplasty and or angiojet of the brachial artery at the time that you explant the vessel. And so it might not be a bad idea to have an access in that ipsilateral thing to pick it up sooner, but a lot of the times after 3 days, almost 50% had laminar thrombus at the explant site because the vessel is about 5.5 millimeters and the device is close to 5.5 millimeters. So the flow is sluggish the minute you put the device in, and you're not adequately, perfectly anticoagulated throughout the entire time that the device is in. So I think it's obvious, but it's just one of those things we need to keep in mind. So let's quick mention about transcaval. I think we need to do more transcaval. I've done one case when I was at Banner, but I think we need to do more transcaval cases. I think especially for 5.5 impellers, because I think it's a tremendously simple and very useful approach in patients that Bashar was talking about requiring higher volume of flow in shock, especially if they're of high BMI. So it's very simple. You do a CT scan, you can see that's the renal, this is the IVC, and you can see that they're very close, and there are many areas in the below the renal that they are actually very close to each other and suitable for access. As long as there's no calcium or minimal calcium, that access is not difficult. And so this is how the setup is. It's pretty simple. You just take a telescopic catheter, you take an Astato, you electrify the Astato, and you cross. You have a snare in the aorta, and you basically crossed over. Once you've snared the aorta, you just basically advance that up. You dilate up the tract a little bit, and then you are able to put a Lundequist into the, here's the Lundequist going up. And once the Lundequist is up, and then you can just put your sheath up and do whatever you need to do. So I think the closure requires a little bit of help, and having a vascular surgeon to collaborate during that would be of great benefit. I've spoken to Segrist, and he's more than willing to help us if we ever came into a situation and needed this. He's willing to even be in the lab when we close in case we need to put an occluder or help us manage a complication. So here's that device going up. It'll obviously stick at that entry point, but again, the physiology of how this works is that the pressures in the retroperitoneum are higher than the pressures in the IVC, so the exsanguination is not extravascular. It's usually a fistula that's created that needs to be closed, and very rarely is there a need, maybe 8 to 9% of the time, a need for alternative treatment like a covered stent graft. What's that? Yeah. Yeah, exactly. But you close that with an ADO 6.8, and it usually closes. And once it closes, you're done. With a adductor occluder on the way out. ADO 6 on the way out. Again, so my advice for alternative access and good femoral access is to plan wisely so that you have to show superior judgment and don't have to show superior skill. Thank you. That's pretty much it. Yes. It does, but I think the challenge will depend on how tortuous the innominate is. If the innominate isn't too challenging, then it's fine, I think. But most people are right-handed, so the default is left axis.
Any questions? Right. Two comments about the femoral axis and the ultrasound. Always like anterior axis, that's important. Nothing happens from good happens from the side axis. And if you're verifying your needle after the ultrasound, please do it in the right oblique view. Because often you do it in the AP view and you think you're above the femoral head and you go right oblique and then your stick is too high and then you miss it. So those two things about tips about the common femoral artery axis and ultrasound. Now we're heading to our break. I want to thank our exhibitors, Abiomed and Livanova and Boring Company. So we gonna, what time is it right now? 10:40. We're a little bit behind, but I think we're having great discussions, great talks. So we'll take 20 minutes break instead of 30 minutes. Please visit the exhibit hall. There is food there. Get yourself familiarized with the exhibitors, and then we'll resume at 11 o'clock.